Today our topic of learning is blood groups. In this we will discuss about different blood grouping systems, blood transfusions, associated investigations and clinical correlations. Introduction to blood groups. Blood typing is a method of classifying blood into different blood groups depending on the presence of different antigens on the surface of red blood cells, RBCs. Understanding the different blood groups is vital in preventing complications from blood transfusion. ABO grouping system. Erythrocytes, RBCs, have multiple glycoprotein antigens attached to their cell surface. The most important are ABO antigens, which determine a person's ABO blood group. An individual inherits one ABO allele from each parent, with A and B alleles being codominant and producing the A and B antigens respectively. 1. Group A. Have antigen attached to the erythrocyte cell surface. 2. Group B. Have antigen B attached to the erythrocyte cell surface. 3. Group AB. Have both antigen A and B attached to the erythrocyte cell surface. 4. Group O. Have neither antigen attached to the erythrocyte cell surface. Each person also has ABO antibodies in their plasma, which will recognize and attack RBCs expressing foreign antigens. These antibodies develop over the first months and years of life. This is crucial in blood transfusion as giving someone an incompatible blood group can be potentially fatal. The A and B antibodies are predominantly IgM. 1. Group A. Have anti-B antibodies. 2. Group B. Have anti-A antibodies. 3. Group AB. Have neither antibody. 4. Group O. Have both anti-A and anti-B antibodies. Now let's discuss another blood grouping system, rhesus grouping system. The second most important blood grouping system is based on rhesus, Rh, antigens. There are many different Rh antigens but only 5 are clinically significant: D, C, E, and E. Rhd is the most immunogenic, i.e. likely to produce an immune response, and therefore the most likely to precipitate a transfusion reaction. The presence or absence of Rhd antigen on the erythrocyte cell surface determines whether the person has Rh positive, Rh plus, or Rh negative, Rh minus blood groups. Rh positive have the Rhd antigen and can receive both Rh plus and Rh minus blood. Rh negative lack the Rhd antigen and should only receive Rh minus blood. Rh negativity is generally more prevalent in Caucasian populations, 15%, than Afro-Caribbean, 8%, and Asian, 1%, populations, but prevalence varies in different parts of the world. Anti-D antibody is usually absent in Rh patients, until they have been exposed to Rh-positive erythrocytes. Rh-negative patients should not be transfused with Rh plus blood as this can cause them to develop anti-D antibodies. This may cause transfusion reactions in the future. Alongside ABO and Rh blood groups, there are many other grouping systems based on other antigens. These antigens can also, more rarely, cause transfusion reactions. Clinically important stuffs. Blood transfusion. A person should not receive blood products containing antigens for which they have the corresponding antibodies. Transfusing an incompatible blood type will precipitate a potentially fatal transfusion reaction as the recipient's ABO antibodies attack the donor's antigen, seen as foreign. Patients having blood transfusions need to be frequently monitored, particularly at the start of each unit. People with blood type O negative are universal donors. They can donate their blood to anyone. This is because their RBCs have no A, B, or Rhd antigens which the recipient's immune system could attack. People with blood type AB positive are universal recipients. They can receive blood from anyone. This is because their plasma does not contain anti-A, anti-B, or anti-D antibodies, so they will usually not mount an immune response to the donor blood. Clinical stuff. Hemolytic disease of the newborn, HDN, anti-D antibodies cause the most severe type of HDN. Exposure of a Rh-negative person to the Rhd antigen causes Rhd sensitization. For instance, during a first pregnancy if the fetus is Rh positive. The presence of Rhd antigens in the maternal circulation stimulates the production of anti-D antibodies. Maternal anti-D antibodies recognize and destroy fetal Rh-positive RBCs. Upon first exposure, the antibodies are IgM, which cannot cross the placenta and will not cause issues in the first pregnancy. However, Future Rh-positive pregnancies will result in the production of large amounts of Ig anti-D, which can cross the placenta and cause hemolysis. Thankfully, the administration of anti-Dig prophylaxis to unsensitized Rh-negative mothers has significantly reduced the incidence of HDN caused by anti-D antibodies. The prophylaxis works by destroying fetal RBCs that leak into the maternal circulation, reducing the chance of Rh desensitization. Clinical stuff. Blood typing and cross-matching. Blood typing, also known as a group and save, followed by cross-matching, helps avoid transfusion of incompatible blood types. ABO typing tests the patient's blood for the presence of A, B antigens, and A, B antibodies. This is followed by Rh typing. The lab will also screen the patient's blood for atypical antibodies. Cross-matching involves mixing the donor's blood with the recipient's blood to detect any immune reaction. Clinical stuff. Antiglobulin testing, Coombs test, direct antiglobulin testing, DAT, detects whether a patient's RBCs have antibodies directly attached to them. Coombs reagent binds to specific immunoglobulins on the RBCs. It is added to the patient's blood. A positive test results in the RBCs agglutinating, clumping together. A positive DAT indicates that hemolysis has an immune etiology. Causes include autoimmune hemolytic anemia, hemolytic transfusion reactions, and HDN. Indirect antiglobulin testing, IAT, detects antibodies present in the patient's plasma. This can be used in cross-matching or to detect maternal anti-Dig. Donor's RBCs and Coombs reagent is combined with the patient's isolated plasma. Again, the test is positive if agglutination occurs. This indicates the patient has antibodies against the antigens present on the donor's RBCs.